Good evening and welcome to Epidemiology Matters. My name is Marissa Sobelson and I am your host. And tonight we are taking a look at a brand new study that has significant implications in the way coronary heart disease has affected new populations. So we are joined here by Mr. John Denning, an expert. Welcome, Mr. Denning.
Thanks for having me.
So let's dive right in. What is coronary heart disease?
Coronary heart disease is the result of atherosclerosis, which is a buildup of a plaque made of sort of fats and cholesterols in the major arteries that supply blood to the heart. So this plaque can narrow or even block these arteries, compromising the heart's oxygen-rich blood supply. This leads to symptoms ranging from angina, which is just a temporary chest pain, to myocardial infarction, commonly known as heart attacks. And it's the number one cause of death in the United States, killing 370,000 people a year.
So what causes CHD and why is it so common?
CHD has a wide range of risk factors, including smoking, high blood pressure, high LDL or bad cholesterol, high blood sugar due to poorly managed diabetes. And so since the best treatment for CHD is prevention, we want to know all the ways in which simple interventions like changes in diet, exercise, and environment can help reduce the incidence of CHD in the community.
And this study is interested in one of those risk factors in particular.
Exactly. So vitamin D does a lot of important jobs in our body, as we know, and helps promote healthy bones, for example, but it also reduces inflammation. And since inflammation is one way in which the coronary arteries can end up resulting in heart disease, you can see that one way vitamin D might help prevent CHD is by reducing this inflammation. So in order to use the vitamin D we get from sunlight or in our diet, however, our body needs to metabolize it. So first, the liver changes it into an intermediate that we call 25-hydroxyvitamin D, or 25-OHD, and later the kidney converts it to its functional metabolite. So we can measure blood levels of this intermediate, this 25-OHD, as it circulates through our bodies, and other studies have suggested a link between low 25-OHD serum levels and an increased risk of CHD.
Very interesting. So let me get this straight. If we know that low 25-OHD is bad, why do this study? To find out the answer to that question, we'll be right back. Welcome back to Epidemiology Matters. We're now going to go a little bit deeper to understand the research question and study population. And for that, we are joined tonight by Elizabeth Sousa, a research scientist with the project. Welcome.
Thank you.
So tell us more. What was the research question and study population in this particular project?
Well, while we know that low 25-OHD is bad, the linkage between this and an increased risk of CHD has only been rigorously tested in white populations. Since low 25-OHD is neither a necessary nor a sufficient cause of CHD, the study of other races and ethnicities who may have different concentrations and metabolization of 25-OHD is needed to gain a better understanding of the association between 25-OHD and CHD.
And what population did you choose for this study, and why choose that population in particular?
Well, it was necessary to choose a population that is suitably diverse in ethnicity to compare relative risks within each ethnic subpopulation. The study population is a source population, including American adults of white, Black, Hispanic, and Chinese descent, who are between the ages of 45 and 84 and have no prior history of cardiovascular disease. Ultimately, some of the individuals were excluded due to high 25-OHD concentrations that suggest high-dose vitamin D supplements. Others were excluded due to a lack of any follow-up data from the initial survey.
Yes, we'll be very interested to hear more about those exclusions from our last guest tonight. But how did you recruit for the population sample?
Well, recruiting was done at 6 field centers of the multi-ethnic study of atherosclerosis, which we'll call MESA from here on out. Informed consent was obtained and subjects completed self-administered questionnaires as well as interviews that were standardized to obtain a broad range of lifestyle data. Blood serum samples were tested for 25-OHD concentrations, and past medical histories were also gathered.
Fascinating. So, can you provide an overview of the study design?
We designed a cohort study looking at participants in the MESA between July 2000 and September 2002. Baseline serum 25 OHD concentrations were measured and then assessed ongoing through May 2012. The primary outcome is incident CHD, defined as the first occurrence of any one of the following events: myocardial infarction, definite and probable angina, resuscitated cardiac arrest, or CHD death. A secondary outcome was more restrictive definition of CHD that included only incident myocardial infarction, CHD death, and resuscitated cardiac arrest, which we labeled hard CHD events.
Very, very interesting. So let's talk about data. What data did you collect, and how did you obtain that data?
Well, researchers collected information on a lot of variables, including demographic and lifestyle characteristics, medical history, anthropometric measurements, lab data, leisure time versus physical activity, average frequency of consumption of specific foods, dietary vitamin D intake, BMI, blood pressure, cholesterol, intact serum parathyroid hormone, and kidney filtration rate. In order to collect the data throughout the study, phone interviews were conducted at intervals of 9 to 12 months, and participants were asked about their hospital admissions, cardiovascular outpatient diagnoses, and deaths. And any self-reported diagnoses and deaths were verified in order to ensure accuracy.
Thank you very much, Ms. Sousa. We'll be back shortly to hear from Allie Riley about analysis. Welcome back to Epidemiology Matters. We're so pleased to be joined by Dr. Allie Riley, a research scientist with the project. So, Allie, tell us about how the analyses were conducted in this study.
So all of our analyses were conducted with STATA 11.2 using a 95% confidence interval.
Okay, and how did you measure potential associations?
So since our study design inherently created the potential for loss to follow-up, which is some people dropping out over the duration of the study, we used incidence rate to assess association between 25 OHD concentration and CHD risk. Incidence rate, or risk, in relation to the total time each person contributed to the study before either dropping out or developing the disease. The rate being higher or lower among the exposed than unexposed can be interpreted by the rate ratio.
That's very helpful. So, what is this 95% confidence interval that you mentioned? Can you explain why that's important?
Definitely. So in general, in all studies, especially when you're looking at the development of a disease in a population due to an exposure, just sampling a random and representative population will often not represent this exactly. Because of this, epidemiologists use confidence intervals to help us understand variability in study estimates due to chance in a sampling process. In general, confidence intervals around measures of association, in our case incidence rate, put bounds around range of associations to reflect possible unequal distributions due to chance.
Fascinating. And did you find any associations in the study?
Yeah, so we did. First, when we looked at the participants' baseline characteristics, which were the level of education, gross family income, self-reported health, etc., and their CHD events, we found the overall mean serum 25 OHD concentration to be 25.5. We determined this to be significant, so we can conclude that race and ethnicity was associated with differences in participants' baseline characteristics. When looking at the incidence rate of CHD events at our follow-up median of 8.5 years, we found this to be 7.38 events per 1,000 person years. But overall, the purpose of our study was to examine if there's an association between 25 OHD concentration and CHD events. And when we looked at this study group as a whole, we found the incidence rates of CHD to be higher among those study participants that had a lower baseline serum concentration.
And was this true when you looked at CHD incidence by different race and ethnicities?
So this is where the study produced some interesting results and ones that further validate why we needed to view this hypothesis within specific race and ethnicity populations. Within each group, we found CHD incidence rates from anywhere from 4.41 to 8.61. And we further looked at the 95% confidence interval findings of serum concentration levels in CHD events within each group. And when we did this, we found a strong association between lower serum 25-OHD concentration levels and a higher risk of CHD events only among white and Chinese participants.
So even though the mean serum for the overall study population supported your hypothesis, you're saying this wasn't supported when looking at it based on race and ethnicity?
Exactly. We only found a significant association of 25-OHD concentration levels in CHD events among white and Chinese participants. There is not a meaningful association among Black and Hispanic. But overall, these results only partially confirm our hypothesis that lower levels of 25-OHD concentration are associated with CHD events in different races.
Excellent. So let's talk about the internal validity of this study. How are you sure that your results are valid within the study?
That's a great question. So there's something called internal validity in all studies, and the goal of internal validity is to design a study with a narrow population of interest that minimizes potential sources of non-comparability, like confounders, selection bias, and misclassification of study participant results. We were aware of all of these, and we made sure to control for them.
Excellent. So let's talk about confounders. I know that can be a major concern in any study design. What are the confounders, and were any of them present?
Yeah, so again, a confounder is a factor that contributes to non-comparability between the exposed and the unexposed groups. For example, in our study, potential confounders included BMI, smoking status, educational attainment, just to name a few. These are considered confounders because many unhealthy characteristics are linked with lower 25-OHD concentrations. But again, we controlled this through our study design. For example, if we look at smoking status, in this confounding situation, we could observe smoking status associated with both the exposure of 25-OHD concentration and the exposure of interest, which is our CHD events. While there could otherwise appear to be a direct association and therefore a causal relationship between the 25-OHD concentration and the CHD events, we found that in truth, after adjusting for the third variable of smoking status, there is no causal association.
Now, Dr. Riley, you mentioned selection bias as a potential source of non-comparability. What do you mean by selection bias?
Yeah, so in general, a study or the results could be considered biased if non-comparability isn't controlled for. However, in our study, how we selected our sample and how we followed up with our population minimized this. As Elizabeth mentioned, we recruited at 6 different MESA facilities with few restrictive criteria for participation in the study. We selected people between 45 and 84 years old with no CHD history. And by taking percentages of each ethnic group that matched national health population statistics, our study tried to reflect the source population as accurately as possible.
Okay, but what about selection bias? Like the fact that not all participants may have had quality health care and good access to that care given their connection to the MESA facilities?
That's a good point, and this is a source of selection bias since members of the source population with limited or no healthcare access would not be represented in our study. And if this were the case, it would lead to biased results in the direction of what we call non-correlation. But however, we accounted for this in our study design by controlling for many of the factors among study participants that could be contributing factors to this bias, such as diet, exercise, and medical history.
Thank you. We've heard a lot in the news lately about misclassification. How did your study control for this?
Yeah, so misclassification, as we've heard in the news, can occur when a study is trying to measure a difficult variable, and more commonly when results are reliant on self-reporting from participants. Usually, misclassification will lead to results that are underestimates of true association. But as we do with all of our non-comparability sources, in our study, one potential source of this misclassification was using the single measurement of 25-OHD, and we did control for this. We consider this misclassification to be non-differential because the change in exposure of this level is equally possible for all participants. So just overall, we're extremely confident that we maintained the internal validity to produce good results for our study.
Dr. Riley, thank you so much for those insights, and we'll be right back. Welcome back. To finish up this episode, we're going to hear once again from Mr. Denning, an expert with this study. We want to think, Mr. Denning, about really what does all of this mean and why is it relevant? So to start off, how much variability is there between different populations in their risk for CHD with these specific exposures?
Well, every disease has a genetic component, and different people have a wide range of responses to different treatments depending on their genes. So you could look at it on a much wider level. You could say, such as you have a high prevalence of a disease like Tay-Sachs amongst Ashkenazi Jews due to a shared genetic heritage. So, more robust genetic screening before having children can help you greatly reduce the incidence of that disease. But you can also look on an individual level. So there are conditions like long QT syndrome. It's a genetic defect that causes heart arrhythmias, and it can be life-threatening. So even though multiple genes influence LQT, you have some version of the disease that can be treated with beta blockers, but one version can actually be made more deadly by the reduced heart rate caused by those beta blockers. So that requires you to think of alternate treatments and diagnosis through careful genetic testing. So you can see that whether it's looking at population trends or family history or a single patient's genome with precision medicine, all patients benefit from personalized treatment. Medicine is far too complex to generalize from clinical studies within an ethnically homogeneous source population. So with this study, in the case of low 25-OHD levels, that study results indicated that Black and Hispanic people do not have the same correlation between those low levels and increased incidence of CHD. We can look for several possible explanations related to genetic variations in metabolism. And so, as you can see, the same 25-OHD levels in a white patient who might have an incidence of CHD, a Black patient could have, say, a higher affinity for the enzyme in their kidney that converts that 25-OHD to its active state. Essentially, the available 25-OHD in the Black patient's blood is used more efficiently, and this greater efficiency may be enough to offset the risk of CHD for that vitamin deficiency. From here, it's clear that more focused tests would be needed to confirm what mechanisms might contribute to this difference between ethnicities for 25-OHD levels and CHD, and adjust care accordingly for people at risk for CHD depending on their ethnicity.
Excellent. Thank you, Mr. Denning, for that fantastic summary. Clearly, there's no question that this pioneering study is going to change the way we think about CHD, not to mention the way we conceptualize of disease causation and intervention by race and ethnicity.